York City Health and Hospital Equity, Diversity, and Inclusion Committee. Today's meeting is officially called to order. Please note for the record that Karen Sahelier is representing Molly Wasser Park in a voting capacity. Next on the agenda, I would like to propose a motion to adopt the minutes of the Equity, Diversity, and Inclusion Committee meeting held on September 9, 2025.
So moved.
Thank you. Call each member. Dr. Katz?
Yes.
Karen Sahelier?
Yes.
Vanessa Rodriguez?
Yes.
For myself, yes. Next is a diversity and inclusion update from Evelise Mendez Justiniano.
Good morning, thank you. So this morning I will be joined by Dr. Davis, who will be presenting on the Equity and Access projects. I will be providing the overview of the activities that the EDI office has been doing throughout the year and the latter part of the year. We're going to start with a recap of education and capacity building throughout the system. For our sexual harassment prevention training program, we have had a total of 46,889 completions system-wide, which brings us to a 97% completion rate. The remaining trainings are all ad hoc or by choice trainings. Identifying and managing unconscious bias is strongly recommended and also goes towards diversity required training overall. Should I continue?
Okay.
Next slide, please. In terms of our leadership development, specifically with gender, we have our Women Who Lead sessions. We continue those sessions. In November, we featured our Senior Vice President of Human Resources, Yvette Villanueva, who spoke on resilience and navigating healthcare challenges. In December, we had Vice President Ms. Divya Pathak, who also had a conversation on data-driven decision-making. These features are meant to provide different individuals of different backgrounds and provide and share their leadership trajectory with other aspiring leaders throughout the system so that they can look at different paths of growing in their careers. Continuing with our educational assistance programs. So we have had a total of six programs that we've had. One of them is the National Health Service Corps, the Nurse Corps, the Loan Forgiveness Program, Nurses Across New York, or NANI as it's called, our Group 11 Tuition Reimbursement Program, our OMH Community Liaison, Community Loan Repayment Programs, and our Public Service Loan Forgiveness. On average, each of these programs is targeted towards different titles. On average, the open period ranges for about 2 months for individuals to be able to apply for any of these programs. In the public service loan forgiveness, from the time that we started centralizing that at New York City Health and Hospitals, we have actually saved our employees around 4.8 million. And it must be noted, these are self-disclosed numbers. So there may be individuals that have participated in this, and those numbers may actually be higher if they have not let us know that they received the monies. In terms of language access, we have had over 30,447 million minutes of interpretation. We have had our Spanish, French, and Bangla are our top 3 languages. And we have user feedback has been very positive for over-the-phone interpretation as well as video remote interpretation, with an average of 96.8 satisfaction rate, which is based on over 400,000 calls rated from January 1st of 2025 to December 9th and 2025. And this is part of our regular assessment of our language access services from the point of view of not only our staff, but also the patients that receive interpreter services. For the year, we had over 40 million minutes of interpretation in over 173 unique languages. In 2026, as part of our continued focus on language access, we will have the EPIC integration launch, and this will allow individuals to access interpreters within EPIC, keeping interpreters on EPIC screens or transferring the calls to interpretation cart. The calls will automatically be documented within EPIC with the interpreter ID, call time, language, and duration. And what this does is, again, it minimizes the time, even though it's really short right now, that it takes to actually connect to an interpreter. In addition to that, This year, we have also focused on written translation. So last year and the beginning of this year, we focused on interpretation services, and we had an RFP for that, and we have new contracts. This year, we have the translation RFP is live. We are actually in the process of awarding the contracts and starting the contract negotiation process. In terms of veteran support services, we continue to have our veteran pop-ups, and these are individual sites and individual events that connect free resources provided by New York City Department of Veteran Services. We had a Veterans Resource Expo that took place on October 22nd here at 50 Water Street. This brought together a variety of veteran organizations, services, and information, as well as honored our veterans and their sacrifice. Now, as we continue looking at our data, throughout the year, one of the things that we've noticed in terms of the trend lines is that we have a self-reported number of about 250 individuals that identify as veterans throughout the system. And so as we have been hosting the veterans pop-ups, it has been very well attended. As time goes on, we start seeing that the attendance has dropped, which tells us that we may have reached saturation in that particular program. So we are now pivoting in terms of strategy. We are launching a Veterans Advisory Council. We're also going to be working with the inclusion groups so that the employees can tell us how we can best serve them. We're also partnering up with our New York City Department of Veterans Affairs, our commissioner, who has been a wonderful partner. And we're going to be offering military cultural competency training so that our physicians can have more of an outlook on how to communicate with our veteran population, those employees, or the patients that may be coming in. We are also looking at providing a Veteran Services website and digital patient navigator toolkit, which is a guide to help veterans navigate New York City Health and Hospital system, as well as our community partners. We also have our We Salute You campaign, a campaign that honors veteran services while also encouraging veteran or active military employees to voluntarily disclose their military status, which means that we will have more of a look at how many employees are actually veterans, and we will be able to serve not only our employees, but also our veteran patient population within the communities that we serve. We're also looking this year at hosting live webinars featuring veterans guest speakers. In terms of LGBTQ and equity, we had Transgender Day of Remembrance, which we celebrated on November 20th, Transgender Awareness Week, November 13th to the 19th, and Transgender Awareness Month throughout the month of November. In commemoration, the Office of Diversity, Equity, and Inclusion, we hosted a virtual vigil. Over 370 employees attended the vigil, which is one of our highest numbers to date. It was a substantial increase from previous years in which we had the event, and this is due to a difference in the strategy that we use for marketing the event. We also moved the event from 11 to 12 to 12 to 1. So the availability for staff to attend these events was increased. We also increased outreach via system-wide emails, flyers, as well as a diversity spotlight letter. Transgender Day of Remembrance, we honored the lives lost throughout the past year. We also shared the system resources that we have to support our patients, our staff, and our visitors. And then you can see we have some comments from attendees that included they very much appreciated that there was an opportunity to reflect on the lives lost and to learn about resources here in our system. Also appreciated that Transgender Day of Remembrance was honored and that the negative impact on Black trans women was specifically highlighted. Happy to announce once again the Long-Term Care Equality Index for 2025. In May, all 5 New York City Health and Hospitals post-acute facilities were recognized as LGBT long-term care equality leaders by the Human Rights Campaign Foundation and SAGE. And of note, since its exemption in 2023, New York City Health and Hospitals has consistently achieved LGBTQ long-term equality leader designation and the LEI. For reference, the LEI is the only national benchmarking tool focused on LGBTQ plus inclusion in residential long-term care and senior housing communities. Across participating nursing homes throughout the nation, only 11% earned the highest leader designation, and we are included in that 11%. Now, as part of the LEI requirements, We had 67% of staff who completed the new Bill of Rights for long-term care residents who are LGBTQ. That's a total of 2,463, which is well above the 50% required for attainment of this designation. In December of 2025, we started collecting and submitting evidence for the 2026 LEI, HEI, which is for all the acute facilities. So that award is expected to be announced in May of 2026. As of right now, we have met all the requirements to be designated as an equality leader for our acute sites as well. In terms of communication and marketing, this is highlighting all of the events, all the communications that we've sent out from September to 25. Some highlights include the Cultural and Impact newsletter was updated. Look and Feel also included multicultural observances, training, events, and opportunities to connect. In October of 2025, we had system-wide newsletters highlighting Indigenous Peoples Day, Sukkot, Diwali, among others, as well as different facilities and all of the work that they've done to promote DEI at their facilities. In November, we highlighted Veterans Day, Native American heritage, transgender awareness. And then in December, we had Pansexual Pride, International Migrant Day, Hanukkah, among others. The Culture and Impact Year in Review highlighted the departmental wins of the 2025 calendar year and was disseminated system-wide. In terms of community engagement, this is just highlighting some of the events that we've had. This here is actually from the veterans event that we did, and one of our speakers was one of our very own chiefs at Queens, who also happens to be a veteran himself. Any questions?
So, Dr. Katz?
No questions. Great job.
Karen Sahiller?
No questions, great job. Oh, a comment. I commend you on getting 98% on the sexual harassment prevention training, because every agency, including mine, and I'm over DEI, it's a struggle to get the numbers up. So congratulations on that.
Vanessa Rodriguez.
No questions. Really great work.
So I have two comments. One is I think it's wonderful that you were able to revive the LGBTQ plus participation. I think that's wonderful, and continue with the great work on that. And what a beautiful calendar.
Oh, I actually have one more information.
Sure.
So this is the first year, because the calendar has been so well received system-wide. We actually now made it available digitally to all staff. So when staff log on, they can find it on their desktops, and they're able to note any information that they want to note on their actual calendars.
Very nice.
Very nice. Very nice. Thank you. Next is an update from the Equity Access Council, Dr. Nicola Davis.
All right. So good afternoon, everyone. So I'll be giving an update today specifically about the Equity of Care work group of the Equity and Access Council. The work group lead is Dr. Eisenstein, who is seeing patients today. So I'm presenting on his behalf and the behalf of the work group. Next slide. So the two projects that I'm going to focus on today are facilitating access to kidney transplant and expanding care for our patients with sickle cell disease. And here you can see our leads for each of the projects. So first, focusing on kidney transplant. So a part of why we got interested in this work and really engaged is back in 2022, we eliminated race from EGFR, from how we calculate kidney function here. And we were also the lead institute joining the Department of Health in the Coalition to End Racism and Clinical Algorithms, and we're still active participants in that coalition. We also received a Doris Duke grant to help us to look and evaluate the impact of that algorithm change, and that work is ongoing. And part of that work was really also looking at assessing our transplant access. Next slide, please. This is just showing you a paper that we published in New England Journal of Medicine. That was a perspective piece about the work that we've been doing at health and hospitals with race-neutral kidney function. Next slide. So in terms of transplant access, H&H, we're not a transplant center, so we don't do transplants within health and hospitals. But we were questioning whether or not there was anything that we should be doing to support our patients who are candidates for transplants. And we started thinking about this a couple of years ago. We started a working group back in 2024 where we were really trying to understand whether there was a gap, what that gap was, and whether or not that was something that we could intervene on. And what we found in that work, talking with our transplant centers, was about 64% of our patients who were referred for transplant did not progress to getting on the wait list. And a lot of that was because of incomplete workups, or they may have financial or insurance complications. So back in January, a year ago, we started a pilot where we hired an inaugural transplant navigator. Okay, next slide. So we focused the pilot just on kidney transplants, and we focused our geography just in Brooklyn. As I said, this was a pilot, so we weren't going to start with the entire system. This is our main area of focus. And the role of the pilot is really to outreach to patients who were identified by either their PCPs or the nephrologists who are potential transplant candidates, and really doing a lot of patient navigation as well as education for those patients. The Navigator also started to have monthly meetings with the local transplant centers, and these have been really insightful. During these meetings, the Navigator is reviewing the list of shared patients. They're identifying whether or not there's any outstanding workup or any barriers to having the patient progress to the transplant list, and really helping to troubleshoot across the system. So we'll have a set of information, the transplant center will have a set of information, and really trying to bridge those gaps is what the navigator will do. Next slide. So this is some of our initial data on the transplant navigator. So for this, we are really looking again just at kidney transplant. And we are looking at specifically Woodhall's, Kings, or South Brooklyn, because this is concentrated just in Brooklyn. Looking at the first year of the Navigator up until October, she has engaged about 154 patients up until October. She's engaged more since then, and has had 677 encounters. And you can see to the right, when you look at the table, you'll see that 16% of these patients do not have a PCP. And that is a real opportunity for us to re-engage these patients, because this is a really medically complex population if they're on the transplant list. And to imagine that they're kind of, floating without a PCP, this is really an opportunity for us to engage them. Next slide, please. So on to our care of patients with sickle cell disease, another project that we're really excited about. And I just want to say hi to Dr. I'm sorry.
Well, I'm sorry, hi. But to go back, in the transplant, the question of the PCP, should not the nephrologist be the PCP? I mean, as much as, I'm the, ultimate, like you, advocate for primary care.
Yeah.
In certain circumstances, you don't have to be a primary care doctor to be primary care, right? I mean, it seems like if your nephrologist is trying to get you a transplant, you stand a good chance. If your nephrologist, is not really connected to you, you don't. So when you say primary care, are you thinking of, you and me, or are you thinking of a nephrologist?
They don't have a primary provider,
Okay.
which may be the nephrologist or PCP.
And am I right that it ideally would be a nephrologist?
Yeah, I mean, they're usually plugged in at that point primarily to a nephrologist, but they still do need a PCP because the nephrologist may not be doing, let's say, their breast cancer screening.
Right.
So,
I mean, your greatest focus, which is the huge disparity, is how these patients do not get kidney transplants at the same rates.
exactly.
Right, which is, I mean, it's a life-transforming intervention.
Absolutely.
Right, and it's horrible that there is the huge disparity.
Right. And that they get just lost in the shuffle
Correct.
of trying to get the transplant and not know, sometimes it's just a test that they needed to get. Like they didn't get their echocardiogram. and they didn't understand all of the tests that they needed to have done in order to further move along that transplant pathway.
Yeah.
Yeah.
Understood. Yeah.
So the 16% that don't have a PCP, is the navigator helping to engage them into one of the Brooklyn sites?
Absolutely. Yes,
Do
that's,
we know how many out of the 16%?
we don't know yet.
And within the sites, how organized is the process of the transplant? Because again, I'm thinking, primary care doctors, you and I, good as we are, we might not know all of the things that have to get done. That's why I was, trying to think who is the right doctor to do it.
And I think that's really the crux of the problem is that they're not necessarily organized. So the patient could be referred, but then they're not being walked through all of the different steps that they need to take in order to get to the point of getting the transplant. So the transplant centers are doing some of it. The PCP or the nephrologist might be doing some of it. There's some things that we can do on our side that to make it easier, as long as we can communicate all of that information to the transplant centers so that they're not also trying to redo the echo or get a cath or get all of the testing that needs to be done. So that's really the goal of the navigator, is to help to streamline those processes and to help the patient to keep the multiple appointments, because sometimes the patient doesn't even understand
Sure.
all
And
of the things
you
that they
need the
have to do.
navigator no matter what.
Yeah.
Even if your clinic has a perfect algorithm, you need the navigator because somebody has to be working directly with the patient. But what I'm wondering is the part of the problem that you'd want a health system to fix is its own stuff.
Right.
Right. You would want what the navigator is doing is explaining the very well organized system at the clinic level and making sure the patient goes to it and solving transportation stuff. But if the clinic itself is not well organized for what of the things that are necessary, I sort of feel like that's on us, right? That's our problem to fix. That's not the patient or the navigator,
Yep.
right?
Absolutely, I agree. And I think that there are different levels of organization, but a part of it is also which tests do the patient get where, right? So if they need an echo, it's not clear that they're always going to get those tests on our side at our facilities versus do they get them through the transplant center? So there's not a clear system as to we've structured that everything we do for our transplant patients are A, B, C, and D, and then the transplant center does, E, F, and G. So there's not such a clear system.
And Nicola, do we have a nephrologist who really, lives and breathes this for transplant? And can we get him or her
Yeah.
to sort of spearhead some sort of effort to do exactly what you're saying, which is right, it's like a negotiation with the transplant center.
Right.
You do these 6 things, we do these 5 things, we do them in this order. You could build an epic tool around it if you felt that was helpful. Not always helpful, sometimes helpful, but
Yeah.
it seems like we need champions who live and recognize, among medical interventions. Renal transplant is just like off the charts in terms of, quality of life,
Yeah.
medical expense, longevity, right?
Absolutely. Yeah, I think we can get there. I think now, first of all, in terms of the champion, Dr. Wagner is a superb champion for all of this work and is a strong partner. We're working very closely with him. But I think now that we have the communication with the transplant centers, I think it's easier for us to get there, because before they weren't necessarily getting results from here. So now that we have the communication, we have, things like Epic CareLink. So I think now we can really set up those systems where these things are done at health and hospitals, and the information can get to the transplant center, and then the transplant center can do other, whichever other things they need to do.
Do we work with multiple transplant centers, I assume?
Yes, we do.
What are the leading ones, do you know?
Sinai, Downstate, NYU. And we've been working closely with Downstate and NYU on some of this work,
Interesting.
but we
Thank
work
you.
with many of them.
Yeah. I mean, I'm also thinking, does Wagner need like a project manager for some period of time, right? It sounds like a project manager job, doesn't it? Like, right, it's all about, what is the process of this happening?
Yeah, no, I think you're raising fantastic questions. These are all things that we've been thinking about. So I think as we finish assessing this first wave of the pilot is where we're going to try to think, okay, what else needs to be done? How do we tweak? We're right now thinking about how do we grow? Are we going to do now kidney in all of the boroughs because we just focused this in Brooklyn? Or do we think about now other organs? So there's a plethora of work to be done in the space. And we're just trying to think about the best way to approach it. So if we can get a project manager, I think that would be great.
We could provide a project manager. I mean, I think one of the things I've always thought was interesting about navigation and navigators, as much as I believe in them, they are also a condemnation of the system. Right. They're saying you get people navigators because you believe your own system is too complicated for a patient to be able to get what they need. And therefore, they have to have somebody to get them through your very own system. Right. And then you kind of wonder, well, why is it we can't fix the system rather than hiring people to help people get through something incredibly convoluted? Why can't we make it simpler, and then maybe they need less navigation because you've made it simpler for what has to happen? I'm, as much as I like navigators, I'm always suspicious of the idea when someone tells me that you need a navigator. I'm always thinking, well, maybe you should make it easier so that people don't need so much navigation, right? Is that really necessary, right? I know some transplant centers try to do a single day as one of the implementation steps, that they just book everything on a day. And that's the standard, on Wednesday, you're right, you're gonna have the echo at 10, and of course, we don't do that, no. We don't even do that for simple things. But it kind of makes sense, right, when you think about it, right?
Yeah.
And all the navigator has to do is get them there that day. And then everything is scheduled, and then you essentially have a prototype, right? Each day, we have this whole suite reserved. But I've seen one system that did that and thought that it made a big difference. I don't know.
And it makes a lot of sense. Yeah, maybe it makes too much sense.
I mean, I think once you like really get it down packed in Brooklyn, then think about spreading. I
Right.
think once you have it down in Brooklyn, I mean, it will be a piece of cake to kind of mimic the same process in the other boroughs. Instead of okay, now let's look into the other boroughs. I think you should really just focus on that first. And that would be really good.
I totally agree with Vanessa. One borough and one organ.
Yeah.
Right.
Right. Exactly.
Right.
exactly.
Right. You got to fix kidney
Yeah.
Right.
Kidney,
before you try to
yes.
deal with liver, which
Exactly.
is way more difficult anyway.
Exactly.
But if you could fix it for liver, then you could go onto. If you could fix it for kidney, you could go on to liver.
Yeah. And I have to say the response from the transplant centers have been great. It's one of those. I was literally speaking with the navigator this morning. She was just commenting to me. She was just celebrated a year with us, with the organization, and so her reflections were that they've been so receptive. It just really feels like this was a link that was missing. There was one patient that was kind of in the list for a while, not really making much traction and not moving forward. And for the first time, she got like the provider on the H&H side in communication with the transplant, team, and it just made such a difference to just connect those dots because I guess, you know, people just don't pick up the phone and call each other anymore, right? And so the navigator was just able to bridge those gaps between the physician teams, and it just made a difference in helping, the workflow and helping to move the patient through the system.
Well,
So.
the transplant centers have taken a lot of deserved criticism for the huge racial and ethnic disparities on who's getting kidneys. So it's in their interest
Absolutely.
to connect with us to try to fix the disparity, because at the end of the day, people look and say, well, but, this is so disproportionate, and doesn't look good for anybody, right? So I'm sure they do feel some motivation, but trying to fix the system would be the most successful. Anyway, it's good work. I'm sorry, I didn't mean to
No, it's
interrupt the introduction.
Next slide. Can we- so our next topic is sickle cell disease, and speaking of clinical champions, Dr. Rivlin is here today, who is I don't to say a big champion seems like an understatement because he has really profoundly changed how we manage sickle cell and has been just such a force here for sickle cell at Health and Hospital. So thank you for joining, Dr. Rivlin. So some of the work here is really focused on how we expand the care for our patients, primarily our adult patients with sickle cell disease. So H&H, we are one of the largest providers of sickle cell care in the U.S. We have 6 centers that focus on pediatric care for patients with sickle cell disease, and we only have 2 adult centers focused on sickle cell disease. And we see that there's a real drop-off in the engagement of patients from pediatrics to adulthood. In pediatrics, we have about 79% of our patients have a PCP in peds, but for adults, we only have about 40% of our patients. So that's a little over 1,000 adult patients with no H&H PCP who have sickle cell disease. We also know that sickle cell disease, it's a single qualifying diagnosis for health homes, so these patients are eligible for enhanced care coordination through the health home. And we know that this difficulty in accessing sickle cell services really contributes to the fragmented care that we see, the higher rates of emergency room visits, and inpatient stays.
Thank you.
Next slide, please. So this is just some data from our dashboard that has looked at our adult patients with sickle cell in the last calendar year, 2025. So you can see here that we have about 1,761 patients that are unique patients with sickle cell, and those patients have accounted for over 17,000 encounters in the system. So if you look on the left, you will see the number of patients that have visited in these different areas. So you see that by far the largest number of patients are going to the emergency room, and the number of encounters for the roughly 1,000 patients is over 5,000 encounters. And you also see the inpatient setting and number of encounters in the inpatient setting are also really high. And we really want to figure out how we flip that so that we are having more encounters in the adult medicine and in our sickle cell centers, but in our outpatient settings as opposed to coming to the emergency room and the inpatient.
Nicola, though, don't you think the cancer center must also be doing sickle cell? I mean, they can have that number of patients who have a cancer.
No, I think it's infusion.
Oh, you think it's an infusion, but not
I think
it's not care?
Yeah.
So the cancer center,
Go ahead.
the cancer center is, they have their hematologist there, but they're part of the cancer center. So you'll see a few patients being followed in the cancer center as part of hematology.
Okay, so a few, but not, you think most of it is infusion?
Most of it is infusion.
Right. Right, because I was trying to total, you see, I mean, it's hard to know, right, because we don't know what the overlap of the 514 and the 327 was. If there was zero overlap, that would be pretty good, right? If you believe that 840 patients out of 998 were either had a primary in adult medicine or a primary in sickle cell. Because as with the previous one, right, if you have sickle cell, it's perfectly reasonable that your primary is sickle cell clinic, right? You might benefit from a separate primary, right? Or, I mean, again, I go back to, in HIV, right, we were primary even though we were specialty, right? We did do cancer, screening on people with HIV, right? And I'm sure that's the same in Vanessa's clinic, right? So you don't have to be a primary care doctor to do primary care, but sometimes it doesn't happen, right? So but here it could be that most of the 327 are part of the 514. We don't know.
Could be, because those are not unique
Correct,
patients.
right. Are you going to show us the percentage that are on medication? No. Do we yet know that?
We don't know that for adults. We know that for up to 21. And it is 80% is on disease modifying therapy from the pediatric side to 21.
So that's pretty good. It'd be nice. Is that something we can know, Nicola, from the data?
I think that's something we can work on. There's a new way that it's getting documented in Epic, right? So that's something that we're moving towards getting to know.
Okay, because I also think, you always want to have the right outcome, right? The outcome that brings the most value. And at least from what I understand about management of sickle cell, that's the outcome that makes the biggest difference,
Yeah.
right? I mean, you want people on disease modifying treatments, right? And it's nice if they have a doctor, but if the doctor's not doing the right thing, it's not going to make that big a difference.
We could go to the next slide. Yes. So our goals when we're thinking about the expansion of care for our patients with sickle cell, we have several goals. One of them is having a warm handoff, the transitions from pediatrics to adulthood, so we prevent that drop off that we're seeing in that transition time period. And then to have patients, for them to have access to outpatient infusion services for when they have pain episodes, as well as integrating psychosocial support services. So our progress to date, again, this is something we've been working on for a while. We developed and had the business plan approved back in 2024. 2025, we were finally able to actually launch with that final approval of the business plan to expand our adult services. And we also received a grant in February 2025 to provide some workforce development, some education for the workforce.
Do most of our sickle cell disease practices do both children and adults, or do most of them do only one or the other?
Most of them do. We have 5 to 6 centers that do purely pediatrics, and they graduate to adults, but it's clinic care on the adult side. So a place like Jacobi Hospital, they'll graduate to me. I will try to transition them to a adult nurse practitioner to take care of them, but most of them wind up leaving the system or just getting episodic care. And if at a place like Jacobi, there is a hematology clinic. It's 1 day a week, but it covers all the hematologic problems, and it doesn't provide the true support that sickle cell patients need.
Yeah, and maybe this is that part of what we're going, I assume, Nicola, that's what your expanded adult Yeah, I think this is clearly, you've identified a group of people for whom our current services don't make sense. And you need, right, to be sending them from a specialized sickle cell disease clinic to a once a week hematology practice. And I can't imagine that even a very good primary care doctors would be able to put together what people would need, right, living with sickle cell.
Exactly.
Okay, well, it sounds like you solved the problem.
Working on it. Um, so, uh, so, um, so our expansion here, we did not have any adult services for sickle cell disease in Harlem or the Bronx. Um, and so that's a major part of the expansion is to have a new clinic for adults that is at Harlem Hospital. And then our other parts of the expansion was to enhance the existing clinics that were at King's and at Queens Hospital. So that expansion includes for each of the clinics, we're staffing them with at least one full-time provider. There's more than that at King's because of their volume. They have a high volume of patients with sickle cell. But they're all getting staffed with at least one full-time provider, a community health worker, as well as access to social work services. So Harlem Hospital, we've hired the physician and the CHW, and we're anticipating that that clinic is going to start in January.
January 26th.
Oh, so we're excited about that. Kings County, we've hired a CHW in the fall, and we have an additional physician and social worker that are in credentialing right now. And at Queens Hospital, we had a provider in place, and we've added a social worker there as well. Next slide.
I think it would be good to see the data similar to the transplant on like which hospitals have the most patients with sickle cell. I think that that would be a good focus on even because I know you said the Bronx. There's no place for patients to go in the Bronx, so I'm assuming the closest would be the Harlem Hospital. So it would be good to see just the N number for each hospital that has a total number of patients with sickle cell.
Yeah, we can absolutely share that. We have that data. I think part of the Bronx is also Montefiore has a really large
Okay.
center, so we thought Harlem Hospital was going to be the opportunity there. But I can share with you the volume of patients with sickle cell at each of our hospitals.
I know Hillary is looking at how to redo our quality measures, because we don't want to always have the same quality measures, because, right, you should achieve them and then retire them and then come up with new ones. I would be very supportive if we could do a quality measure on percent of sickle cell patients on a disease-altering medications as a quality measure, so that we would focus on that and, be able to say how that number is changing.
Okay. Yeah, we have a meeting about the QAPI board metrics coming
Right,
up, so
but I
can
think
mention
that'd be a good one.
Next slide, please. So these are essentially the metrics that we will be looking at, both operational and clinical. So I think you see the clinical metric there. Dr. Katz is the one you're talking about.
Right.
And then these are the different operational metrics, PCP engagement, ED visits, inpatient admissions, the volume, infusion center volume, et cetera. Any other? And that's it from my end. Any other questions?
Katz? Karen Sahilier?
Awesome report. Thank you. I learned a lot today.
Mr. Rodriguez? So for me, I've seen this in many hospitals that the one thing that has changed the quality of care these patients are getting is making sure that they have access to direct care when they're in crisis, not having to go through the emergency room. So I look forward to us really developing on this goal quickly so that people understand that we're offering this service and that they're more prone to use it. And hopefully we can retain some of the people transitioning from pediatric care to adult care, because they feel that love lost immediately, I can imagine, right? After that first ED visit, once they age out. So I look forward to this. Wonderful job, both on the transplant and this, and thank you for presenting.
Thank you.
Thank you.
Well, any old business? Any new business? There being no further discussion, meeting adjourned. Thank you.
This meeting is no longer being recorded.
This meeting is being transcribed and summarized.